A very good evening to all of you. Sorry for interrupting Nukkad Natak in between, since it was just for the wait time, and now we are formally starting our program. Once again, a warm welcome to Brandos. Brandos is the Breast and Endocrine Society of Western UP, where on a monthly basis, we all the clinicians with a special interest in breast and endocrine surgery, we meet on every last Friday of the month. It's an online academic program where we discuss about breast and endocrine related problems on an alternate basis. For those who are new, I'm Dr. Sudhi. Kamboj. I'm consultant and head Department of Breast and Endocrine Surgery at Nutima Hospital, Meerut, and alumni from KGMU and SGPJ Lucknow. And today we have a very interesting session. So before that, I would like to first introduce you about the program, which is a problem-based learning program. So what is unique in our program? The uniqueness is that we pick a clinical problem that we see in our day-to-day practice. We pick that program, we discuss about that clinical problem in detail with actual images, with the help of the clinicians, those who have actually managed those patients, with the help of pathologists, radiologists, nuclear medicine physicians, urologists, nephrologists, whosoever is ever involved in the management of that case. We usually invite them to come and present their aspect also, so that we have a comprehensive understanding about that case, because we all know breast and especially the endocrine, they have a multidisciplinary approaches. So we on this forum we understand each other's aspect, so that we are able to enhance our learning and are able to manage that patient in a proper way. So on every even month we have a breast meet, on every odd month we have endocrine meets. October being an even month, this time we have an breast meet, and by chance October is also breast cancer awareness month, so this is an opportunity for us to learn something very basic about the breast cancer management, that is genetics in breast cancer. So not taking much time, now I am sharing my screen, and first what I'll do is to introduce you with today's problem. What is the exact clinical problem that we are going to discuss, then the learning objectives, then I'll introduce to you our guest speakers and the guest faculty, and something about asoma. So please be with us. Thank you for joining once again. Now I'm sharing my screen. One of the very unique aspect of this program is कि in this program, इस program में we used to have a common interactive language. हम आम बोलचाल की भाषा में भी अपनी बातें रखते हैं, ताकि हमारी अंडरस्टैंडिंग बेटर रहे और हम ज़्यादा से ज़्यादा इंटरेक्टिव होकर अपने पॉइंट्स रख सकें. तो लैंग्वेज इज नो बार, यूजली वी डिस्कस इन प्रेफरेबली इंग्लिश और इन हिंदी एंड इंग्लिश टू इनकरेज मोर डिस्कशन फर्स्ट. सेकेंडली, हमारे प्रोग्राम की खासियत है, इसमें इनवाइट करते हैं गेस्ट फैकल्टीज को हु आर stalwart in that particular field, so that we get to know from them कि whatsoever management that we are doing, what is the current status happening in their institute, which is a high volume institute. So we learn from each other, from a low volume, middle volume to high volume. We all come together on the same platform. थर्ड इम्पॉर्टेंट है कि हमारे इस फोरम में ये मल्टीडिसिप्लिनरी है, बिकॉज लाइक we know in a particular our own specialty specific forum we discuss about our own points, but we never try to understand the point from others, from other specialties. So in this specialty we have a blend of community. It is a blend of community, so it is an open community and we discuss from each other and learn from each other. So friends, not taking much time, हम आज का केस शुरू करते हैं. Who is a 36-year-old female. She is primary 1, delivered 7 years back, adequately breastfed. She presented to us with complaint of bilateral mastalgia. So what was important in her case? She had a family history of breast cancer in her mother, who died due to disease at very early age, at the age of 35 years. And she being a single child, so we did not have much family history related to her mausis or mama. So we didn't have much history related to from her paternal or maternal side, except that her mother died at a very early age. with breast. On clinical examination, mammography, we did not find any suspicious lesion except that she had a dense breast and she had a fibrocystic breast disease. But her main concern was she was worried of her risk of breast cancer, and she requested for some tests so that her risk assessed. And now we thought of, okay, BRCA1 and 2, these are the two most common mutation that are being studied in breast cancer. Let's see, assess whether she's BRCA1 or 2. So our complexity further increased when from one lab, when we inquired, okay, what is the cost of this test? They quoted around 26,000 rupees for index. And from another lab, when they came to our contact and we asked, they said, okay, it is only 6,000 rupees. So our confusion further increased. Okay, why the same test is costing? There's a huge difference between the test cost in two labs. So we have taken the advantage to learn from this forum what are the various tests available to assess the risk of genetic breast cancer. We have a high clinical suspicion of breast cancer. Patient is asymptomatic, but her family history suggested. Is it possible we can detect any genetic defect in that asymptomatic patient? So what are the various tests? अगर हम टेस्ट कराते हैं, what are the reliability of those tests? Why is there a huge cost difference among labs for the same test? तो क्या ये कोई टेक्निकल इशू है जो हमें नहीं पता, या ये दे आर टेकिंग एडवांटेज ऑफ इग्नोरेंस ऑफ वी हेल्थ केयर प्रोफेशनल्स? What is the best test to screen an asymptomatic female with high risk family history or a diagnosed breast cancer patient with red flags for genetic breast cancer syndrome? तो हो सकता है पेशेंट एसिम्टोमेटिक हो, उसकी फैमिली हिस्ट्री बहुत आई हो और पेशेंट हमारे पास आया हो कि ओके हमारा रिस्क आप असेस कीजिए, या फिर उसको ब्रेस्ट कैंसर डायग्नोस हुआ है और उसको कुछ ऐसे रेड फ्लैग्स हैं जिससे हम सस्पेक्ट करें कि हो सकता है इसको जेनेटिक ब्रेस्ट कैंसर हो सकता है, तो उसके लिए क्या टेस्ट अवेलेबल है। और इस चीज को डिस्कस करने के लिए हमारे साथ हैं आज डॉक्टर दिव्या उचिल, who is MSc in Genetic Counseling, BGCI certified level 2 genetic counselor. She is currently working as a senior genetic counselor and scientific affairs manager at 4 Base Care Onco Solutions. Or I'm very fortunate and I'm very thankful to Professor Chintamani sir. He as such needs no introduction. However, still for those who are from some far-flung places or new to this society, he is the Chief of Breast and Endocrine at Vardhaman Medical Center, Medical College, Safdarjung Hospital, New Delhi. And he has so many laurels in his, and among them, he is the president of Asian Society of Mastology. ये एशियन सोसाइटी ऑफ मेस्टोलॉजी की डिटेल्स मैं आपको अभी बताऊंगी, और वो बहुत इंपॉर्टेंट है आप सभी के लिए जानना कि आपको ये सोसाइटी क्यों ज्वाइन करनी चाहिए। He is teacher of teachers. So many professors, those who are teaching at various institutes, and he is the teacher of those teachers. So before we start our program, there are few disclosures. These programs, the Brendos programs, are never sponsored. So today's program is not sponsored. There is no conflict of interest. And please, it is a purely academic program. Please enjoy it to the fullest, learn maximum from this forum today, and ask as many questions as possible. And before I finish, Asian solutions to Asian problems. Friends, we all know we blindly follow the Western world. We know that their profile is absolutely different from we Asians, we Indians and the Asians, but we blindly follow their data, treatment profile, and other things. So to overcome this, there is a society, for those who don't know about this, is the Asian Society of Mastology. तो ये एशियन सोसाइटी है, मेस्टोलॉजिस्ट है, मेस्टोलॉजिस्ट ऑल द क्लिनिशियंस विद अ स्पेशल इंटरेस्ट इन breast diseases, in the management of breast diseases. It is a society for them so that we can learn about the breast cancer profiles and their specific treatment, especially in Asian population like India. तो ये हमारे लिए बहुत पर्टिनेंट है। 15 से 18 नवंबर के बीच में अभी अपकमिंग एसोमा कौन है कॉन्फ्रेंस है, और एक छोटा सा वीडियो मैं जरूर दिखाना चाहूंगी, ये सेंसिटाइज करने के लोगों को कि अगर किसी को जरा भी इंटरेस्ट है इस तरह की चीजों में अपने आप को और अपस्किल करने का, मैं उन्हें रिक्वेस्ट करूंगी और सजेस्ट करूंगी कि वो बिल्कुल इस कॉन्फ्रेंस को रजिस्टर करें और ज्वाइन करें, इसकी वर्कशॉप ज़रूर अटेंड करें।
Various ways to skin a cat. You should learn one correct way at least. And then you can modify it to suit your own personality. The same thing can be done differently. All you, in any case, whether you're doing a level 1 of the plastic, we do the circular. For this recipe, the first exercise is don't get close. Here. Quick. That sheath is there. Go for it. You can see there is another. This vessel going up. Put it inside.
Stroma of fibrous tissue, fat, and linear densities, which are the Cooper's ligaments, the blood. This is the axillary tail of Spence, and it's important to remember, particularly when we do surgery for risk reduction in BRCA carriers. So we have seen carcinomas occurring in the axillary tail of Spence, and so these are all some abnormal lymph nodes about to spread. So some names are given. With a name, you'll never forget when you see. Here there is on the periphery of the node. Always ask for the previous films and compare it with the previous film. A developing finding, developing asymmetry, a developing lesion could be significant.
या फ्रेंड्स, होप यू हैव एंजॉयड, आप लोगों ने एंजॉय किया होगा और ये बिल्कुल बहुत ही इंटरेस्टिंग सा कॉन्फ्रेंस है। And I must congratulate sir. Chintamani sir is the brainchild of, and please give him a big round of applause. And we all wish a grand success of this upcoming ASOMA concert. इसकी डिटेल हम सर खुद बताएंगे, ASOMA के बारे में सर बताएंगे आफ्टर दिस प्रोग्राम। सो एट द एंड ऑफ द प्रोग्राम जो लोग भी इंटरेस्टेड है, मैं रिक्वेस्ट करूंगी वो हमारे साथ बने रहे। दे कैन आस्क एनी क्वेश्चन रिलेटेड टू जेनेटिक्स इन ब्रेस्ट कैंसर या ASOMA कौन से रिलेटेड कुछ भी पूछना चाहते हैं, सर उसको खुद ब्रीफ करेंगे। आप उनकी वेबसाइट पे जाके अपने आप को रजिस्टर भी कर सकते हैं। सो नाउ आई रिक्वेस्ट दिव्या मुचल जी मैम, नाउ यू प्लीज टेक ओवर. Should I provide you the...
Thank you so much. Thank you for the introduction. Thank you for having me over here. It's indeed a pleasure to be a part of a session like this, which is a sole initiative to empower people, enlighten them about real world problems that we face every day. And I think we need more such programs in India, so that more and more of our clinicians are aware about the different problems and they know how to cater to them. So without much delay, I will just try sharing my screen. So a very good evening to everyone. My name is Divya Uchil. I am working as a senior genetic counselor and scientific affairs manager at 4Base Care. We are a genetic testing company both into germline as well as somatic testing. Today's topic will be going deep into the genetics of breast cancer, and हम ज़्यादातर germline testing की बात करेंगे. Slowly, I will be taking you through all these different words. So when we talk about cancers, generally आप cancers को 3 parts में divide कर सकते हो: sporadic cancers, familial cancers, and hereditary cancers. Out of which sporadic cancers, the one which are not passed on through family, generally form the major chunk. Then you have familial cancers, which is about 10 to 15%, and then hereditary, which is 5 to 10%. I know दिखने में hereditary looks like a very small portion, a very small chunk of all the cancers that we have. But it looks like in India, especially, it is known that this incidence rate is quite high of hereditary cancers. One probable reason for this can be that we have a lot of intra-community breeding. So everybody tends to get married to people within the community, जिसकी वजह से जो gene pool है वो within the community ही concentrated रहता है, या within the same geographical region concentrated रहता है, और उसकी वजह से hereditary cancers का जो proportion है, जो मात्रा है, वो इंडिया में काफी ज्यादा है in comparison to the world. When we talk about hereditary cancers happen because of germline mutations. So what is germline and what is somatic? So germline mutation is something which comes from the parental gametes. This mutation is present right from the parental gametes. That's why it's present from the embryo stage itself. And this particular mutation, since it's coming from the parental gametes, it is present in each and every cell of our body. In the entire body, in each and every cell, this particular mutation is present. So as we know, even the gametes which come in, जो genes form होते हैं, हर gene के 2 copies होते हैं. Generally, अगर हम बात करें hereditary cancers की, तो hereditary cancers are caused due to a mutation in one of the copy of the genes, जिसका मतलब है कि एक copy mutated होती है और एक copy normal होती है. So अगर आप ये germline mutation वाले part का last part देखें, why it is saying half of the gametes carry mutation is because the one copy of the gene is basically mutated. So one copy is healthy, one copy is mutated. जिसकी वजह से 50% chances होते हैं generally कि ये hereditary mutation एक generation से दूसरी generation में जाए. On the contrary, when we talk about somatic mutations ऐसे mutations हैं जो आपके parental gametes में नहीं present होते हैं. They are not present in the parental gametes. This particularly happens at maybe it can happen at an embryo stage, or it can even happen at a later stage in life. जिसकी वजह से this particular mutation is confined to only one organ in the body. It is not present in the whole body. As we know, cancer is a disease of the DNA. So particularly अगर ऐसा हम देखने जाए तो हर cancer genetic है, but हर cancer hereditary है या नहीं, ये जानना जरूरी है. So हर cancer genetic है क्योंकि हर cancer शुरू होता है या the tumor formation starts only because एक DNA का mutation हुआ है, and that particular DNA mutation has triggered uncontrolled growth of the cells, and that is why the cancer is forming. But when that mutation or that trigger is only restricted to one organ or a particular particular region of the body or the system, it is called a somatic mutation. And generally in these cases, this does not pass on because it is restricted. It is not present in the gametes which will get passed on to the next generation. So these mutations do not pass on, and these are the cancers that we call as sporadic. So the 80% chunk that I showed in the previous slide, जो ज़्यादातर पार्ट है कैंसर्स का क्लासिफिकेशन वाइज, इज स्पोरेडिक, एंड वो जनरली सोमैटिक म्यूटेशंस की वजह से होते हैं, जर्मलाइन म्यूटेशंस की वजह से नहीं होते हैं. नाउ देयर इज ऑलवेज अ कंफ्यूजन बिटवीन फेमिलियल एंड हेरिडिटरी. अ लॉट ऑफ टाइम्स ये काफी ओवरलैपिंग टर्म्स है जिसकी वजह से फेमिलियल और हेरिडिटरी बहुत लोगों को लगता है कि सेम होता है, बट हेरिडिटरी और फेमिलियल में देयर इज अ वेरी थिन लाइन ऑफ डिफरेंस. फेमिलियल इज जनरली cluster of similar cancers in a family. There might not be an inherited genetic cause to this. There might not be one mutation which is causing this. It could be an event of chance. So by chance, because maybe we have the incidence of cancers in general going so high, 2 to 3 people in the same family have got cancer. So that also can happen. So in such a case, we will call such a case will be called as a familial case. Whereas a hereditary case, it is very easily recognizable. You can catch up very easily that there's a pattern in which the mutation is moving from one generation to another. And there is always one mutation, like in these days, we even see 2 mutations, to be honest. So it would be wrong to say only one mutation, but then there is a common cause. There is one common cause, which is basically causing the cancer in all the affected individuals. So if you test a proband, the first index case, the first person to get tested, if you test that person, the mutation which is found, you will be able to find the same mutation in every other person who has the cancer in the family. So that's when you can confirm and tag it as something hereditary. So here I have an example of 2 pedigrees which I have made for better understanding of what I was explaining in the previous slide about familial and hereditary. So like in familial, I said cluster of similar cancers. So here we can see that generally 4 people are affected with breast cancer. And particularly the age of onset is not very early. They have not got cancers at very early ages. And again, the pattern is not very recognizable. So as you can see, this individual who is marked as 2 in the third generation second individual, इनकी जो mother है, she is not affected. She is healthy. इनके सिस्टर को था, एंड अगेन ये जो 52 इयर्स पे हमने प्रोबैंड मार्क किया हुआ है, प्रोबैंड की जो मदर है उनको भी कैंसर नहीं हुआ था. सो पर्टिकुलरली देयर इज नो रिकॉग्नाइजेबल पैटर्न दैट वी आर सीइंग हियर. Whereas on the contrary, when you talk about hereditary cases, you can see that very early age cancers, here again you can call it cluster of similar cancers, but then there is something very recognizable. Somebody is getting a breast cancer as early as 33 years. You can see her mother also had a cancer, and the mother's mother also had a cancer. Similarly here, 38-year-old who is our proband, the deceased at 47 years of age due to breast cancer, and again her grandmother also had a cancer. So like I said, a very recognizable pattern, and particularly very early ages of onset that we are seeing, and that's why we have a very high suspicion of this particular case to be hereditary. Now let's talk about the genes which are involved in breast cancer particularly. So I'm sure BRCA1 and BRCA2 are very, very famous, very popular genes. Everyone keeps talking about BRCA1 and BRCA2, especially in India. And I think everyone talks more than it should be actually. Definitely not taking the hype away from BRCA1 and BRCA2, one of the most important genes, pretty high risk, and since they're so well studied, there is a really good management plan available. So it's important to diagnose BRCA1 and BRCA2 for individuals. So how did BRCA1 and BRCA2 gain all the fame? So I'm sure the picture on the left side, most of you are aware who she is. Yes, she's Angelina Jolie, the renowned Hollywood celebrity. So क्या हुआ था was in May 2013, Angelina Jolie, उनको पता चला that her mother had a cancer. Mother had ovarian cancer, and उनकी जो grandmother थी, mother की mother, उनको भी ovarian cancer हुआ था. Angelina Jolie has not had any kind of cancer yet. She is healthy. But उन्होंने May 2013 में out of curiosity अपने doctor से पूछा that, I think there is something going on in the family जिसकी वजह से my grandmother, my mother have had these similar cancers, and I feel like I can also be at risk of it. So is there any way to know it? So that's when she was introduced to BRCA testing, and she underwent BRCA testing, and she turned out to be positive for BRCA1. After turning out to be positive for BRCA1, she took the bold step. She wanted to completely prevent the disease, since very understandably she must have seen the disease too closely in her family, because of which she did not want to not take any chance at all. So she underwent a double mastectomy along with a risk-reducing salpingo-oophorectomy. So BRCA1 में the major risk for females is of breast cancer and ovarian cancer, and she took steps to completely get out of it and prevent it. Another very bold step that she took was she did not just want to manage it and keep this information to herself, she actually went on to write an article about it in this particular magazine that we can see, The Time. And she wanted more and more females, more and more women, her age, younger than her, older than her, to realize that maybe they also could have something running in the family, and they also should get something like this, like a BRCA testing done when it's so easily available, and then you can take so many steps for yourself. So as you can see, after ये जो particular event हुआ May 2013 में, it was called the Jolie effect. जोली इफेक्ट के पहले और बाद में अगर आप देखोगे, on the right side I have put in some statistics. So the testing rate, if you see, massively increased. The Google search rates for BRCA massively increased. And what was surprising was it was not just females who did not have, like, who had already had a cancer, but people who did not have a cancer actually went on to taking this test more likely than people who have already had a cancer. So this in terms of the Indian population is something we are, I believe, a little behind with, because there's a lot of fear in our population, a lot of understandable fear, completely understandable. That's where we oncologists, genetic counselors have to help our people understand why this testing is so important for them and how it can actually empower them to beat cancer, not only for themselves, but from their family completely. So talking more about BRCA, the hereditary breast and ovarian cancer syndrome is what BRCA1 and BRCA2 mutation causes. As we know, who do we generally suspect for a BRCA mutation or BRCA testing? People, individuals, females with breast cancer diagnosed at or before 50 years of age, ovarian cancer at any age particularly, because now we also have PARP inhibitor benefit for individuals detected with ovarian cancer and BRCA mutation, multiple primary breast cancers, whether in the same breast or in the contralateral breast, male breast cancers, very important. Again, awareness about male breast cancers in the population is as good as zero. It's important for males to understand that they also can have breast cancer, and when you have a male breast cancer, BRCA testing definitely is something which should top the priority list to get tested. Triple negative breast cancers, recent studies have shown that triple negative breast cancers generally turn out to be positive for BRCA1. And then, of course, if you have a combination of pancreatic, prostate, or breast, ovarian cancers in the family, and more importantly, if you have a family history. So if you do not have a personal history, but you have a family history of any of these cancers which are mentioned above, then definitely need to see a genetic counselor, understand your risk, and go ahead for testing if required. So this is just an example about, just to give you an idea about why we are talking so much about BRCA1 and BRCA2, because the risk figures drastically increase if you have a BRCA1 or BRCA2 mutation in comparison to the general population risk. Of course, this general population risk that we're talking about is of the Caucasian population in this data. We know that breast cancer risk in our population, the Indian female population, is anyway higher than 12%. But when you have a BRCA1 or BRCA2 mutation, it raises it as high as almost an 84 or an 87%, which means that there's only a 10 to 13% probability that if you have a BRCA1 mutation, you will not get a cancer throughout your lifetime. Again, having a second primary in the breast, that's also pretty common when it comes to BRCA1, BRCA2. Ovarian cancer risk also drastically increases when we talk about BRCA1, BRCA2. Male breast cancer, especially when you're talking about BRCA2, male breast cancer incidence is extremely negligible in the world, is what we can say looking at the data, but it definitely increases to a significant amount when you have a BRCA2 mutation in it. Prostate, pancreatic, and even melanoma is particularly known to be associated with BRCA2. We have a beautiful clinical management plan that the NCCN guidelines provide for individuals who have the HBOC syndrome that are diagnosed or detected with BRCA1, BRCA2 mutations. For females, in terms of breast, you have two options. One, to do a regular screening through self-breast examinations, clinical breast examination, and an annual breast MRI is suggested because of the high risk. You also have an option of complete prevention through prophylactic mastectomy. Ovarian cancer screening, as we know, is not very effective, although there are guidelines which give transvaginal ultrasonography and CA-125 as options for screening. But we know that these tests are not very effective when we talk about ovarian cancer. So generally, it's pretty stressed on the fact to people with BRCA1 mutations that if they have completed the family, they should have a discussion with their gynecologist, oncosurgeon, and opt for the risk-reducing salpingo-oophorectomy. For men in general, breast cancer screening, of course, but what's important, more important, is awareness and education that there can be male breast cancers. Annual clinical breast examination by a clinician, and then for prostate cancer screening, we have the PSA that we do annually. Now, moving on from BRCA to your different other genes which are present. So I think these genes would particularly be feeling really sad about how much importance BRCA gets, but they do not. So that's why I'm going to stress about them more, because surprisingly, in the real world today, we see that there's increasing incidence of mutations in the other genes other than BRCA, especially the HRR pathway genes. They are turning out to be genes like PALB2, BRIP1, RAD51C. These genes are particularly turning out to be mutated in a lot of Indian cases. Again, that's another sad part, that we do not have a database or a statistics about how much of our population has what gene mutation at which position. It's something which is the need of the hour, and we should definitely focus on getting genetic testing done for individuals who are in need of it, so that we also can build a database of our own population database. These are the different associated syndromes that we have. So like I said, these HRD associated breast cancer, mostly genes which fall in the HRR. HRR stands for homologous recombination repair pathway. So that's the HRR pathway. And when we talk about HRD, it's particularly homologous recombination deficiency. So again, here we have other syndromes which are particularly important: Lynch syndrome, Lee-Fraumeni syndrome, Cowden syndrome. Lesser heard about, but these syndromes definitely are more in proportion. It's just that we're not getting enough testing done to actually identify. Like I said, the relevance of HRR genes are particularly increasing because now we have started to have FDA approvals for HRR mutated cancers as well, especially prostate is in start of the race, and we also slowly have data which is coming in for breast cancer also. That's what has been put up here on this slide. So why is it important to go beyond BRCA? Because the susceptibility, the kind of cancers caused, the kind of management changes with respect to the gene which is involved in causing the hereditary cancer. Like you can see here, when we are talking about BRCA1 and BRCA2, and then PALB2. PALB2 is one other gene which is slowly gaining more and more popularity these days, more and more incidence of mutations in PALB2. So as you can see, BRCA1, BRCA2 and PALB2, we do discuss the option of a prophylactic mastectomy, but as you go to the moderate risk genes, ATM, CHEK2, BARD1, we're not really talking about a risk reducing mastectomy here. We are talking just focusing more on a screening plan. Age of onset definitely varies. As you can see, BRCA1, we are starting at 25 years of age, but when it comes to ATM, CHEK2, we can wait up to 40 years of age to start the screening. Again, RRSO is something which is debatable. We don't know whether a risk-reducing salpingo-oophorectomy should be offered to individuals with ATM, CHEK2, BARD1, but when we're talking even PALB2 for that matter, we still don't have data about ovarian cancer and PALB2. Slowly, the data about breast cancer and PALB2 is increasing. That's why the option of risk-reducing mastectomy is available, but for ovarian cancer, we still do not have the data. So, very important things here: the age of onset changes, the management changes, the organs that we are looking at change. So that is why we need to move away from just looking at BRCA, and we need to start looking at the DNA more comprehensively. We need to get more multi-gene panels done, especially when required. In early onset cases, we definitely need to move beyond BRCA to particularly be able to give more efficient management plans to our patients. So a little bit about the different types of genetic tests which are available. So there is Sanger sequencing. These are all different methodologies and different tests. There's next generation sequencing, which I'm sure everybody is aware about. And then there's something new, which I think will be a new learning, which is the multiplex ligation dependent probe amplification, which is MLPA. I will not be talking about Sanger sequencing because practically, I think in today's world, apart from research setups, there is nobody who is doing Sanger sequencing. Sanger sequencing has its own cons, and after next generation sequencing has come, it's proven to be a more cost-effective, time-efficient way to look at more genes at a time. So that is why we'll not talk about Sanger sequencing. Let's talk a little bit about next generation sequencing. So I'm sure आप सबने next generation sequencing के बारे में सुना होगा. Next generation sequencing में हम DNA extract करते हैं, blood sample में से करेंगे यहाँ पे when we're talking about germline testing. DNA extract करके एक library prepare होता है. ये library basically जो आपका DNA है वो छोटे-छोटे fragments में सेपरेट किया जाता है, कट किया जाता है. एंड ये छोटे छोटे फ्रैगमेंट्स को हम बेसिकली अडेप्टर्स लगाते हैं. अडेप्टर्स जो लगाते हैं छोटे छोटे फ्रैगमेंट्स को, वो पर्टिकुलरली ये मशीन में सीक्वेंस करने में हेल्प करता है. सो इसलिए हम ये अडेप्टर्स लगा के हम एक डीएनए लाइब्रेरी बनाते हैं. ये डीएनए लाइब्रेरी फिर जब आपकी एनजीएस मशीन में जाता है तब सीक्वेंसिंग होता है, और सीक्वेंसिंग का डेटा जो आता है वो डेटा पे फिर एनालिसिस होता है. पर्टिकुलरली ये जो डेटा आता है उसमें एज वी नो पूरा डीएनए सीक्वेंस हो रहा है तो बहुत सारा डेटा आता है. इट्स वेरी इंपॉर्टेंट कि आपका जो एनालिसिस टीम है, बायो इन्फॉर्मेटिक्स टीम है, क्लिनिकल रिपोर्टिंग टीम है, वो काफी अच्छा हो सो दैट दे कैन एफिशिएंटली फिल्टर आउट कि क्या हमको चाहिए, what are we looking at, what is important, which genes are important, which regions are important. Look at those things and only particularly focus on them. A lot of advantages. You are basically able to sequence multiple genes together simultaneously with one sample in one go. Whereas Sanger sequencing में generally हमको बहुत सारे अलग-अलग genes के लिए अलग-अलग processes run करने पड़ते थे. This is very cost effective because of the same reason कि आप बहुत ज़्यादा resources and reagents नहीं use कर रहे हो बार-बार एक ही process में और getting done with the whole DNA. Extremely high sensitivity, very less chances of missing something out test. A quick turnaround time in comparison to Sanger sequencing, and again, like I said, very less amount of DNA. Moving on to MLPA. Now, this particular MLPA test, I'm sure आप लोगों में से बहुत लोगों ने NGS reports देखे होंगे. I would want you to go back and check NGS reports of your patients which have come out to be negative. If it has been done from a good lab, and I think these days, I mean, all labs, I think, put in, as far as I know. If you have gotten the test done from a good lab, if the report is negative, they would have definitely put a disclaimer or a recommendation for an MLPA test. So what happens is basically, जो mutations होते हैं, जो defects होते हैं, आपके DNA में जो हमारे hereditary cancer से associated genes है, ये जीन्स में जो म्यूटेशंस होते हैं, डिफेक्ट होते हैं, वो दो टाइप के होते हैं. वन आर द स्मॉल चेंजेस व्हाट दैट वी कॉल एज सिंगल न्यूक्लियोटाइड वेरिएंट्स, एंड अदर आर द लार्ज चेंजेस व्हिच आर बेसिकली योर लार्ज डिलीशंस एंड डुप्लीकेशंस. ओके, सो एनजीएस का एक लिमिटेशन ये है कि अगर लार्ज डिलीशन और डुप्लीकेशन रहेगा तो वो पर्टिकुलर लार्ज डिलीशन और डुप्लीकेशन आपके एनजीएस मेथोडोलॉजी से पिकअप नहीं होने का चांसेस है. सो इट इज इम्पोर्टेंट कि आप ये करें कि अगर आपका सस्पिशन एनजीएस नेगेटिव आने के बाद भी काफी हाई है विद रिस्पेक्ट टू द पेशेंट्स क्लिनिकल हिस्ट्री, देन द पेशेंट शुड डेफिनेटली बी सेंट फॉर एन MLPA फॉर पर्टिकुलर जीन्स ओनली. MLPA is not a comprehensive test. MLPA is a test which is covered for particular specific genes. There is a new technology now that is known as a digital MLPA, but I'm not sure how many labs are offering it. जो डिजिटल MLPA होता है उसमें आप मल्टीपल जीन्स को साथ में देख सकते हो. MLPA टेक पर्टिकुलरली इंडिया में अगर आप देखो तो MLPA टेक्नोलॉजी इज अवेलेबल फॉर BRCA1, BRCA2, जो आपके MMR जीन्स है, 4 MMR जीन्स, MLH1, MSH2, MSH6 एंड PMS2 एंड TP53. ये जीन्स के लिए MLPA अवेलेबल है. सो इट इज वेरी इंपॉर्टेंट कि पेशेंट का क्लिनिकल हिस्ट्री ध्यान में रखा जाए, पेशेंट का क्लिनिकल हिस्ट्री एंड फैमिली हिस्ट्री ध्यान में रख के हमको जीन्स चूज करना है कि कौन से जीन्स का MLPA पर्टिकुलरली कराना है, कौन से जीन में लार्ज डिलीशन या डुप्लीकेशन हो सकता है जो शायद NGS पे मिस हो. I'm sure most of you have ordered genetic test reports and genetic test reports आप लोगों ने देखे होंगे. उसमें आपने देखा होगा कि जो म्यूटेशन आता है वो पर्टिकुलर ये 4 कैटेगरीज में क्लासिफाई होता है. दिस इज ACMG क्लासिफिकेशन, अमेरिकन कॉलेज ऑफ मेडिकल जेनेटिक्स के हिसाब से. देयर इज अ full paper, full guideline which is available, जिसके हिसाब से all labs are supposed to do the reporting, classification of these different variants that they find. So these are basically divided into 4 types. Pathogenic, likely pathogenic are the ones which are particularly associated with the cancer. So this is the mutation which is basically causing the cancer in the family. It proves that the particular cancer is hereditary in nature. Now the difference between pathogenic and likely pathogenic is pathogenic has far more evidence, must be reported time and again, commonly seen. बहुत सारे databases में, literature में इसका mention हुआ होगा, then it's something definitely pathogenic. Another important criteria is कि अगर ये कोई ऐसे डोमेन में लाई करता है प्रोटीन के जो बहुत ही important डोमेन है, जो ये म्यूटेशन होने से शायद वो पूरा डोमेन ही हट जाए या डोमेन पूरा बन नहीं पा रहा है, इट इज गेटिंग रिड्यूस्ड इन साइज, व्हाट यू कॉल अ ट्रंकेटेड प्रोटीन, ऐसा कुछ अगर हो रहा हो तो then it is definitely something pathogenic because we know that the protein is not going to be functional after that. Likely pathogenic जो होता है generally it is more of again something that you can say it's a slight assumption, but then it's more strong, the assumption is more strong than a variant of uncertain significance or a benign. This probably would have been reported earlier. It is associated with a particular domain which definitely leads to loss of function. You can have different softwares which are predicting that it is associated with something pathogenic, but then maybe right now it's not meeting all the criteria that ACMG is giving to call it pathogenic, hence it's called likely pathogenic. A variant of uncertain significance, I'm sure it is something जिसको जो रिपोर्ट देख के हम जनरली अपना सर पीटते हैं कि अरे व्हाट इज दिस, ये क्या आ गया है. So a variant of uncertain significance is basically where there is a particular change, एक कोई change है, एक particular type का defect है जीन में, but as of now उसका function कैसे alter हो रहा है, whether it is something associated with cancer, इसके लिए we do not have enough evidence. जो research databases, जो literature sources हम use करते हैं, उसके हिसाब से it is not qualifying enough to be called as something likely pathogenic or even to be called as something benign. So a variant of uncertain significance clearly lies in a gray zone where it is not something associated with the disease and not something normal as well. So that is why it is called a variant of uncertain significance. ऐसे cases में हम generally patients को बोलते हैं कि 6 months में एक बार आप lab के साथ follow up कीजिए to check whether जो research databases and जो literature है उसमें ये variant के लिए कोई और evidence आया है क्या. Another way to look at a variant of uncertain significance is कि अगर आपके पास दूसरे affected individuals family में से है and this variant of uncertain significance is particularly in a high risk gene, say you have a case of early onset breast cancer and आपको BRCA1 में ही BUS आया है, अगर आपके पास वही family से दूसरे affected individuals available है तो आप उनको ये सेम वेरिएंट के लिए स्क्रीन कर सकते हैं. अगर ये सेम वेरिएंट से 2-3 पीपल में प्रेजेंट हो, ऑफ कोर्स 1 पर्सन के साथ इट विल नॉट बी इनफ एविडेंस, बट अगर 2-3 पीपल में प्रेजेंट हो, सो यू कैन टेल द लैब दैट यू वांट टू रिक्लासिफाई द वेरिएंट बेस्ड ऑन द फैमिली हिस्ट्री एंड द पर्सनल हिस्ट्री ऑफ द पेशेंट, एंड द मैनेजमेंट plan can be given to such patients. But then of course we need to make sure that we have enough evidence. We are saying this with keeping in mind the age, the cancer type, all different things that are involved with the family members. A benign variant is something that you will not see on the report. I just put it for understanding ki not every genetic change or not every genetic variant is something associated with cancer or a VUS. There are genetic changes or variants which are normal. So They are not something which are particularly altering the function of your protein or causing any damage. So they are normal, they are benign, and these variants particularly will be found at very high frequencies, which means that since it is normal, more normal लोगों में आपको ये मिलेगा. So maybe cancer affected लोगों में आपको ये variant नहीं दिखे, but जो normal लोग हैं उनमें आपको ये variant दिखे. Talking about why genetic testing and genetic counseling is particularly important. Now I've divided this into two parts for the affected individuals and the healthy individuals. For the affected individuals, of course, we now have so many treatment related benefits coming in, PARP inhibitors coming in. There is tamoxifen for individuals who are BRCA1 positive. So we have so many evidences for treatment benefits which are coming in. So it is important for treatment, for decision making for particularly the affected individuals, for the selection of treatment strategies. A lot of times, especially when we're talking about breast cancers, like Dr. Sudhi was telling us कि दो options आपके पास होते हैं, whether it is a lumpectomy or a mastectomy. You can choose what you want to go ahead with. Of course, a lot of other factors involved, but जब आप BRCA1 पहले करा लेते हो, if you have a BRCA1 positive status, then maybe the doctor will be more inclined towards a mastectomy than a lumpectomy, because we know that the risk of a second primary is pretty high in a BRCA1 positive case. To prevent or for early detection of cancers in the future, somebody who has breast cancer, अगर आपने उसका genetic testing कराया, BRCA1 positive आता है, so वो risk reducing salving वो oophorectomy कर सकते हैं, which is preventing them from having a ovarian malignancy in the future. There is predictive testing for family members. Family members, like I said, in the case of Angelina Jolie, family members, especially, it's a very ignored and less spoken about topic, but the emotional baggage on the family members and what they go through is something really sad when it comes to diseases like cancer. So when you offer predictive testing to such people, such individuals who have seen the disease so up close, maybe lost a dear one, maybe seen a dear one struggle. So in that cases, these members actually feel like they're blessed to have known about their genetic mutation status, to have known that they can actually start taking steps to not have a cancer in the future. For healthy individuals, like I said, we have multiple options. You have surveillance, you have prophylactic surgeries that they can do, and we also have options like tamoxifen, particularly for BRCA1 cases where they can prevent chemo in the future. Basically. Again, a very, very important aspect where a genetic counselor plays a very important role is dealing with the different psychosocial issues which are associated with being diagnosed with a hereditary cancer syndrome, being detected with a mutation which particularly is hereditary in nature. For both affected and healthy individuals, it comes with a lot of issues, a lot of baggage to actually, live in the fear of getting a cancer in the future, knowing you are a part of a high risk population is something very difficult, and genetic counselors definitely play a very big role in managing such families. So now to talk about the approach to genetic testing, like how we should go about. So this is just my personal opinion and personal experience. This can vary. And I mean, if anybody wants me to reason out why I listed it like that, we can always have a discussion about that as well. So here's the first case where we have a 30-year-old with a triple negative breast cancer and no family history, absolutely no family history. So what would be the line of testing that we will follow for her? Now here, like I said, we will first go with a multi-gene panel test rather than only BRCA1 and 2. Now this multi-gene panel test will have BRCA1 and 2 included here. And if it is negative, then we will go for an MLPA for the BRCA1 and 2 genes only to see if there is any kind of large deletion or duplication. In this list, you can also add TP53, which is the leaf from any gene, that you can do an MLPA for that as well. But again, the probability of BRCA1, BRCA2 is higher than TP53. Here is a second case study where looks like a case of familial breast cancer to me, where our proband who's 50 years who got breast cancer at 50. Her sister was diagnosed with breast cancer at 47, and their mother was also diagnosed with breast cancer at 60 years of age. Not very early ages of onset. So basically, in this case here, if you don't do a multi-gene panel, it is okay. You can stick to a HRR panel, which particularly covers most of the breast cancer genes. Because when we are talking about a multi-gene panel, there are chances that you might land up on a VUS in a gene which is not associated. As a policy, the lab has to report that. Then again, that becomes a little bit of an issue to explain what has come out to the patient. Rather stick to the HRR panel here whenever you have a case of familial breast cancer or breast cancer cases that are not very early onset, 45, 50 years onwards, you can stick to HRR panel. And if it is negative, then you can again, you have to go for a BRCA1 and BRCA2 MLPA. Especially BRCA2 is very important because BRCA2 is associated with later age of onset when it comes to breast cancers in comparison to BRCA. This is a third case study which typically looks like hereditary breast and ovarian cancer syndrome. You can see only CA ovary and CA breast, and you have early onset cases as well. In this particular case as well, I would like to stick to only the HRR panel again, because if there was the involvement of other genes, we would particularly have seen, if you're talking about Lynch syndrome, you would have seen males also being affected. If you're talking about the Leaf-Romani syndrome, we would have seen much earlier ages of onset in comparison to these. Again, when we're talking about Cowden syndrome, we would have seen thyroid cancer also. So breast cancer is not one of the most prominent cancers in Cowden, but one of the prominent apart from thyroid. We have seen thyroid and breast as well. So here again, I would like to stick to a HRR panel, which is particularly covering most of our HRR genes. Again, it serves purpose for treatment as well for the individuals because they all have breast and ovary. So the HRR panel will also help them to understand if they are eligible for PARP inhibitor maintenance. Again, if negative, BRCA1 and 2 MLPA should definitely be offered to these individuals because the suspicion is pretty high when you have a pedigree like that. This is our last case, which is a mix, a complete mix, a very strong history of, a very strong family history on both sides. You have different types of cancers, which you can see here, and some early onset cancers as well. Now here an HRR panel will not make sense. It is more advised to go ahead with a multi-gene panel only because with such wide variety in the types of cancers that you're seeing in the family, you cannot stick to only HRR, which covers only 4 cancer types. So it makes more sense to go for a multi-gene panel. And if this multi-gene panel is negative, definitely MLPA for BRCA1, BRCA2. Again, family history plays a very important role here. If you are seeing more of colorectal cancers, endometrial cancers, esophageal cancers, you can also go for an MLPA of MMR genes. If you are seeing a lot of lymphomas, leukemias, melanomas, sarcomas, you can go for an MLPA for TP53 as well. Unfortunately, right now, MLPA in India, I think widely we have only these genes which is available. If there is any other gene which has a large deletion or duplication, that is one limitation that we face. With digital MLPA, yes, we can cover, but I don't think a lot of labs have digital MLPA, right? So that's all from my side. Thank you very much.
Yeah, thank you very much, Dr. Divya, for such an enlightening. It was really very knowledgeable. I gained a lot from your presentation, and I hope all our other audiences have the same view. So now I open this forum for discussion. We have 2 questions till now, and there are other questions also that I will be asking from both of you, from Chintamani sir as well as Dr. Divya. So one question is from Dr. Maria Mir, who is asking which guidelines are being followed here. You mentioned about some guidelines.
These are NCCN guidelines.
Okay, so I think Dr. Maria, your answer is provided. These are NCCN guidelines which Dr. Divya quoted, and Dr. Bhavika raised her hands. So if Dr. Bhavika is still there, may I request you to please now ask your question? Okay, are you still with us, Dr. Bhavika? Fine. So maybe later on, as soon as she is available. सो द इम्पॉर्टेंट इज, सर मैं पहले आपसे पूछना चाहूँगी, सर आप एक बहुत ही टर्शरी केयर रेफरल सेंटर में वर्क करते हैं, पहले हम समझना चाहेंगे कि आपके यहाँ पे जो ब्रेस्ट कैंसर का जेनेटिक असेसमेंट है, वो कितना पेशेंट रेडली एग्री करते हैं इस चीज़ को लेके? जब आप उन्हें बताते हैं, क्या सारे ही पेशेंट मोटिवेटेड होते हैं जेनेटिक टेस्टिंग के लिए, या आपको भी जगल करना पड़ता है हमारे जैसा?
Thank you. And first of all, thank you, Divya. It was a very nice talk. I thoroughly enjoyed it.
Thank you, sir.
Importantly, you made it simpler for the clinicians because you must understand after a while the genetics gets into your system. It's very addictive for some and repulsive for others. So that is what is why you made it interesting and useful. And like she mentioned, triple negative breast cancer, which I think is the Indian stereotype, we are sitting on a dynamite actually. All of them should undergo the genetic counseling and testing accordingly. And we know that BRCA1 cancers are usually bad histologies. And although it's not been proven completely, because this is our problem that we should be looking at. Many a times, answering your question at the same time, Sudhi, पेशेंट्स को जेनेटिक काउंसलिंग, डॉक्टर्स को भी जेनेटिक काउंसलिंग का कॉन्सेप्ट थोड़ा फॉरेन लगता है. दे थिंक इट इज समथिंग फैंसी and they associate it with the problems of the rich, not of the poor. Sadly, breast cancer in this part of the world has got two peaks, unlike in the West, whereas the age advances, increases, the peak reaches around 60s. And in India, we have two peaks. We detected it in our publication we did in 2004. That time, there was no such concept of triple negative breast cancer. We were just finding out strong family history. Then we found BRCA1, BRCA2 germ cell mutations in these patients. Based on the archived specimen, we found out that they were. Now, we found out they were all triple negatives. That is an eye opener. And I'm glad you mentioned all cancers are gene based, but some, not all, are inherited. So, first thing that we should do, I'm sure, from this forum, is not to scare the hell out of each one. And I'm glad she mentioned that 80 to 90% are sporadic only. And sporadic is also genetic. I mean, it's affecting the gene, but it's not the kind of, the concept that people carry. It's not a hereditary, so it won't pass down. But yes, it's happening in a tumor or in a cell separately. It's not all over the body. And also, the age at which you get it, the chance for it to spread to the other parts, the chances are more. So therefore, younger patients get a more aggressive cancer, and we are not surprised. Now, आपके सवाल का जवाब ये है कि जब उनको हम ये कॉन्सेप्ट दें, उससे पहले हमें ये कॉन्सेप्ट होना चाहिए. So I don't think counseling can be done by somebody, clinician I'm talking about, who doesn't know about it enough. So I found even doctors not being very much aware of the relevance of genetic counseling and genetic testing in these patients. You will be surprised the awareness programs that have been running for last few years. We don't have screening. Naturally, screening cannot be done in this part of the world because the average tumor size is more than 3 centimeters. You need it to be less than 2.5 centimeters, which is again a myth. So clinical breast examination is what we've been trying to do for all these years. But in the process, awareness is increased. So बहुत सारे आजकल पेशेंट्स डेफिनेटली ये हिस्ट्री अपने आप ही देते हैं कि मेरी ग्रैंड मदर को हुआ था, मुझे होने के कितने चांसेस हैं, कोई तरीका है पता लगाने का. And this group of people are usually slightly educated. Now, you understand literate and educated are not the same thing. So many a times when you get people, they are, doing. In fact, there's a lady who's a professor of history at Delhi University. I operated on, she had a locally advanced breast cancer. She has a strong family history. She never bothered. While, a class 4 worker in our hospital, she brought her daughter, mentioning that my daughter should not have it. Can you do any testing? थोड़ा सा मुश्किल है, थोड़ा सा आसान भी है. अब अगर आप अवेयरनेस स्प्रेड करते हैं, जैसे आज इस चीज की बात हुई, when it goes around, when it reaches people, it also instills a little bit of fear. So बहुत double-edged sword है. उसको आप बताना शुरू करें तो ये भी नहीं हो कि उसको लगे it is a disaster. Everybody in the family will get it. People will die of it. Even if you inherit a mutation, you may not get cancer. So this this awareness, I think, is very important. So मेरे ख्याल से उस सवाल का जवाब, I could not answer it well, but my answer would be, if we counsel well enough, they are willing for it. But this is, as I mentioned, considered by a lot of providers also as something that is alien to them. Gradually, they are waking up to it. You see, with triple negative breast cancer, we are sitting on a dynamite, as I was mentioning, because almost all of them need this test. The important thing is, even for therapy now, we need to understand the genetic basis. Even if it is a somatic mutation, we need to find out which drug to use. In ovarian, especially, you have targeted therapies available now. So it is becoming important, but it's getting better. Not to the extent we would want it, but it is getting better.
Yeah, thank you very much, sir. So there are a couple of questions for Dr. Divya. First of all, Dr. Divya, we would like to understand from you. You mentioned about HRR and MLPA, NGS, multi-gene panel. So, who decides who is supposed to decide like which test to prescribe? Like we clinicians कि ओके आप इसमें HRR जीन पैनल करवाइए या आप इसमें मल्टी जीन पैनल कराइए. So is it we, or like it is the we should coordinate with the genetist of that particular lab ki okay ये case है अब आप क्या suggest करेंगे? So
I think to start with, the most ideal way would be to do it in coordination with a genetic counselor or a geneticist who understands better about these syndromes, because I understand, like, as a clinician, can be a little difficult to remember about, which gene and which syndrome and all of that. So it would be best if, in ideal scenario, it would be best a genetic counselor and an oncologist work hand in hand. Of course, with experience, what we've seen is a lot of oncologists who are very much into genetics and keep referring these tests. They slowly have a idea about what should be sent. So in those cases, definitely. And tests like MLPA, I would say they will generally come to you from a genetic counselor only, because tests like MLPA are like a secondary line of tests. It's never the primary line of tests. So only if, say, your first test comes negative, then there's an MLPA which is required. So these tests will always come to you from the lab or from the genetic counselor only.
Dr. Divya, if I may,
Yes, sir.
In the West, I mean, I've attended some MDTs there and been traveling for grand rounds. They have included the genetic counselors and genetic experts in the MDTs now, where the discussion happens when the clinicians also kind of pass on their their opinion about certain things.
Right.
You see, this is a very valid question that Dr. Sudhi asked you, because sometimes there is a possibility. You see, there's so much, like you mentioned about PALP P2, which is essentially for the triple negative, and it is almost always asked for and ordered for. An average clinician would know about BRCA1, BRCA2, and will sleep over it. There is more to it. So that gets discussed in a MDT, and the decision is taken in the MDT. It is signed in the register so that nobody's taken for a ride. The hidden message there was, who is making the patient spend that money? Because actually, they cost a hell of a lot. If I may ask you, how much would it cost to get the MLP as a secondary testing done with BRCA1, BRCA2 already done?
So, sir, an MLPA again is within the same range. Like, I think the most expensive genetic test with respect to, I think somebody else has also asked a question about HRR costing. So I'll just, keeping in mind sir's question and the question that's been asked, I'll just briefly discuss the costs which are there. Now, we're not talking about any specific lab here. I'm just giving a general range or a figure about how much these tests should ideally be costing you. So when you are talking about, like I said, a BRCA1 and BRCA2, in my opinion, this test should never be sent, like only a BRCA1 and BRCA2, because it is not going to, probably going to serve the purpose in terms of a negative report, but, not going to cover the other genes which could be important. So I would always recommend a multi-gene panel, which either can be an HRR gene panel if you're looking at a case which is strictly restricted to breast cancer, ovarian cancer, prostate, and pancreas. Now, this gene panel is available from somewhere around 10 to 20,000. within the range of 10 to 20,000. You also have some labs which give you coupons for BRCA1 and BRCA2 particularly, and there are some labs which have coupons for HRR as well.
Glad you made that point actually, and invariably it should be multi-gene because it's not. You should, if you're wasting. I mean, if you're spending 10,000, you shouldn't be wasting those 10,000. I mean, it's not
Correct.
like you to spend it. Might as
Correct.
well spend 15,000 and get the complete answer because
Correct.
you need to have a diagnostic as well as a therapeutic approach based on that. So I
Correct.
think that's a very valid point, and the cost doesn't look frightening because
And
it is not scary as one would perceive.
correct.
That is what I want. I'm sorry I butted in, but I
No,
wanted the point to be reinforced because I'm glad you mentioned it.
correct. And again, sir, I mean, it is actually, if you actually go to see, there is from with this NGS technology which has come in, there is actually no difference in the process which is followed on the back end. In the back end, every lab will actually run a full multi-gene panel that they offer. It is just that when you select these particular number of genes, say even just two genes like BRCA1 and BRCA2. So if you remember the NGS slide that I was talking about, there's a filter which is added at the last step. So in that filter, they essentially filter everything out except BRCA1 and BRCA2 and then provide you a result of BRCA1 and BRCA2. So
What do you think is the AI going to do? Because we had a talk on it in ICGA conference that we had. I happened to be the board of directors there. So there was a big discussion on AI coming in, that reducing the cost, making it foolproof, more objective, more rational. What do you think about it? Is it going to happen soon or it's already started happening?
So again, I think when we're talking about AI, I feel as a country in India, we're not yet prepared for an AI-based system, mainly because we don't have the data. Our data system is definitely very poor when we talk about, genes which are associated with the Indian population. So we don't know what kind of mutations we have. We don't know what kind of genes are involved, what kind of cancers we have. So I don't think we're very well prepared for an AI-based system because I think that is going to be more biased to a Caucasian population or a Western population data, and there is a probability that it will miss out finding out mutations for the Indians.
Thank you. And that actually answers the question because we are working on ICGA on the lines of TCGA. So Indian Cancer Genome Atlas is going to find out that data. We have
Correct.
multiple centers participating, and we are trying to get this triple negative puzzle sorted. And all that is triple negative is also not bad. We realize that some of
Right.
them are good triple negatives, and there are those bad triple negatives. So I think genetics is where we need to be going eventually, not today, maybe tomorrow. Rather than killing a mosquito with an AK-47, we are walking in in an era of precision oncology, where you have individualized approach to management of every patient individually, which is where AI will come in so that you don't need so many people. But importantly, as she rightly mentioned, if we don't have the data about Indians, so that is why Indian solutions to Indian problems are required. And that is why these talks are important. These talks become important as a launching pad. Most clinicians are not too keen on listening about genetics. They're more into, more and more aggressive chemotherapy has come in, more and more aggressive surgery has come in. Precision oncology is about choosing bare minimum to get more effect.
Right.
That's where genetics would be extremely, extremely important.
Thank you for your inputs. Now, Garima Mehta, ma'am, wants to ask something. She has raised her hand. Ma'am, are you listening us? Would you like to ask a question? Yes, ma'am.
Okay. Hi, Divya. It was very informative and very practical deliberation. Hi, Dr. Chintamani.
Hello, how are you, Dr. Garima? So
I'm
nice.
good. I'm good. How about you?
Very
I'm
well.
good.
Thank you.
Divya, my question is very practical and very encouraging to you. But if you ask patient to go for any genetic testing, and patient is not ready for say bilateral mastectomy or oophorectomy, do you think it is worthwhile asking for this kind of test where patient is not even ready to accept the treatment we advise? What is your take on that?
So, ma'am, I think being a genetic counselor in India, we are posed with more patients like this than patients who are, very acceptive and are ready to get things done. I think again that's a transition that India is making in terms of healthcare, where we are slowly becoming more aware and have started stepping into hospitals before we have any symptoms. So we were always a population which went to the hospital only when the symptom got worse.
It is just like, PET CT.
Correct,
Now,
correct.
now patient comes and says, get my PET CT done, without even thinking about it. And I'm really worried that probably with increasing knowledge and information and spreading news about it, these questions will arise. That if patient is not willing to take these kind of actions, what is the
Correct.
point of knowing whether you are having a high risk gene or not? Dr. Chintamani, your take?
Brilliant question. Actually, I was waiting for Divya to finish. See, this is a major problem. It happened with screening also. And the US task force is not very keen on screening any further, and they've increased the age because you pick up just too many patients who may not ever get invasive cancer, and we spend a lot of money doing it. Importantly, even if you pick it up, and if the patient is not willing for the preventive measures, then what you have done is two things. One, you have found out a problem which may not manifest ever, and she live with that anxiety. And number two, there's nothing you're doing to offer. The only thing, probably the middle path would be, Dr. Garima, to do the active surveillance in these cases, which is something like a middle path. I'm not happy with the situation, because it is worse than not knowing about it, than knowing and then doing nothing about it, because that is kind of a very one, you have spent money on finding out, and now you don't want to do anything about it. So whenever you would agree, Divya, it's not to take away from you what you are speaking. It's a practical end of the delivery. When you're providing when you're doing anything, the outcome is the end point. The end point is important. The end point is, we will find out this lady has 25% chances of developing breast/ovarian cancer. We will offer her either chemo prevention, or we'll offer her some kind of a surgery, right? So the risk reduction surgery, we don't call it prophylactomy, Dr. Divya, because
And,
even,
and, and we increase the anxiety
yes, that's what I said.
without, there's
That's right.
absolutely no level anxiety.
That's right. Absolutely. And
So
Divya,
what?
that is called risk reducing mastectomy, because even the trouble in US, the mastectomy rates have gone up to 55%. Why? Because every lady wants the other side removed, because of the fear of developing cancer on the other side. Where the risk of developing the cancer in continental breast, and without any the one of these findings, so the germline mutations, is less than 2%. So they're getting it removed, while because it's also getting covered by the insurance, so they get their reconstruction done, they have everything done under the same cover. So what probably she's trying to drive home is, while you're adding to anxiety, you're not able to offer anything, and you want the test done. So would it be better not knowing about the problem? Your answer is correct. We are in the transition phase. This phase would also pass, but sadly in this phase there'll be too many anxious people around, who will be thinking like a ticking time bomb inside. They don't have cancer today, but they're thinking about cancer every day, which is worse than having cancer at some point. So that is an anxiety factor which also is to be taken into account. So when you're offering the counseling, so that take home should be from this, we must be very sure that this is a convinced patient who would possibly also take the treatment for preventing it or for treating. Otherwise, there's no point getting it done, because that will make it only worse. This lady cannot afford it, cannot, or is not willing. Like, I think they were doing that act, that one that Dr. Sudhi's team was showing. The other person was not even bothered for getting the triple assessment done. Let it come, let it go, let it go. Finally, it is the anxiety of the clinician also is there. This person has got a problem, but she's getting nothing done, so you can't sleep over it. Both people cannot sleep over it. So that's a flip side, but you have to live with it.
Agreed, sir. And that's why I think a pre-test genetic counseling is also very important. That's why all of these genetic testing cases, where you explain the implications, the pros and cons, what follows after a positive genetic test report to the individual very clearly. so that they know, what they're stepping into and what awaits them.
Absolutely. The
Yeah.
whole thing, therefore, the MDTs with genetic counselor within it really helps because MDT includes the patient as a whole, and
Right.
patient is in the center, and we all sit around the patient. If you sit in the center and the patient around you, then you're likely to lose him or her due to the centrifugal force. The other way around is better. So, surrounded by all treating people who are well wishers and hoping to take care of it as and when it happens, right? And the in the in US, they for the screening of these women, they use MRI also because they are also prone to developing mammography induced cancer, surprisingly. It's very funny, but they really live with that anxiety, so it's a problem.
So what I can extract from this whole discussion is that whenever we have a very high clinical suspicion of having a genetic breast cancer, keeping the medical legal aspect also in our mind, we should always prescribe from our end as a clinician the multi-gene panel for breast cancer, if I'm not wrong,
Absolutely.
multi-gene panel for breast cancer, and let the patient be attached with some genetic counselor so that they are regularly motivated and told about the pros and cons, and gradually, like if we put more and more consistent efforts, will certainly bring the result somewhere down the line. तो धीरे धीरे जब हम इसके बारे में ज्यादा बात करेंगे तो ज्यादा से ज्यादा पेशेंट हम परसेंटेज इम्प्रूव कर सकते हैं अपना समय के साथ. So this was a very pertinent discussion that we have. So the important thing, next question that is there, can you please elaborate? ये जो cost difference मैंने बताया कि आपने कहा 10 to 15,000 and you 40,000 तक के भी टेस्ट होते हैं. नाम सुन के 40,000 many patient decline कि अरे नहीं इतने तो हमारा इलाज हो जाएगा. तो is it due to some, you have told us the details of the techniques that is being used. So is it really due to ignorance of are we doctors, or it is really technical कि वो कुछ होता है क्या होता
No, I don't think there's any technical aspect involved. I mean, I really think 40,000 is too high for a germline test, and 30,000 is like the max, which I know of. So that's the range. Even a multi-gene panel, which is like the epitome of germline genetic testing that you have, which is most comprehensive and covers everything. These days, it's available at 25 to 30,000 easily.
मैक्सिमम अगर बहुत
Maximum, yes, maximum. Yes.
ओके, तो इसमें जो आपने कहा मल्टी जीन पैनल और कुछ में आपने कहा HRR पैनल, तो इज इट मैंडेटरी वी गो फॉर HRR in all patient we can ask for multi gene panel?
Yeah, you can ask for a multi-gene in all patients. It is just that it's always good if you're asking for a multi-gene in all patients. Definitely, that's the gold standard. It's the best because then you're not missing out on anything. But what's also important is, to have a pre-test and post-test genetic counseling here, because a lot of times when you have a VOS in, say, a gene which is not related to the patient, again, we're going to add some anxiety out there. As genetic testing labs, we're bound by ACMG and ESPO guidelines, and we have to stick to, reporting certain mutations if they cross the cutoff. So they have to be reported, but then they might be classified as something as a variant of uncertain significance. So in that case, then we need to take steps as to what to do. So here at 4Base Care, what we've done is basically we try and stick to the genes which are associated with the patient's clinical and family history, and the other genes which probably are not associated go as a separate section known as or additional variants. This way, we have all the mutations on the report, and because this additional variant is on page 2, it does not really add to anxiety to the patient, because the patient sticks probably to the main findings, and the main findings look all clear. And these additional findings are particularly findings in other genes which are not associated to the patient's condition. Say, patient has breast cancer and history of only ovarian cancer, endometrial cancer. We get a mutation in a VHL gene, which is essentially more towards renal cell carcinomas. So now that goes as a secondary finding, like that goes as an additional finding rather than being on the main page. Only the variant of uncertain significance, this is not the pathogenic ones. Pathogenic and likely pathogenic always stay on the main findings page. Only the variant of uncertain significance, if it is in a gene not associated to the patient's clinical or family history, it goes as a separate section.
Okay, fine. Thank you very much. So, friends, today we have learned a lot from our guest faculties, and guest speaker. I request you, if there is any question, अगर कोई भी question कोई पूछना चाहता है, we still have time, and otherwise we'll just wrap and summarize whatsoever discussion we had today.
Important thing is, Dr. Divya, not to hand over a horoscope to the patient. And that is why it is very important to sit next to the clinician, because patient would listen to the clinician more, because that's where the confidence is, And when two, say, so Dr. Sudhi sitting with you and talking to a patient, it's a different ball game altogether. That is very unlikely to happen. So this is why you can do a virtual connection or counseling. This is coming big time. We have tried doing it. So what it does is just you, me, and the patient on the screen and my team. You will be very surprised. They all agree. They all agree. It's not that even I used to think the way others were saying. I don't think it's a challenge. It's more about the bankruptcy of thoughts rather than real bankruptcy. We don't try hard enough, honestly. And the important thing is to educate the providers. They need to know more about the genetic basis to cancer. Actually, there's so much you need to read almost on regular basis to understand that one cancer is different from the other. Within the same person, the two cancers are different. So it's very important to individualize. That is the take home.
Yeah, thank you, sir. And there's one another question that has came up, and that's a very, very important question, because we have seen this confusion among many clinicians. Dr. S.K. Arora, sir, is asking, in multi-gene testing, which sample is being used? Is it blood, or sometimes people are confused with the tumor specimen sample? So which sample do we use?
So today we spoke about germline testing only and about hereditary cancers. So when we talk about hereditary cancers, we look at the germline DNA, which comes from the blood sample. It does not come from the tumor sample. It always comes from the blood sample only. In some parts of the world, there's also saliva sample, which is taken. I think in most of India, blood sample is what is taken, because I think we don't have a lot of those saliva kits available probably. So it is blood sample.
Okay, so Dr. Smita Sharma wants to ask, should we give PARP inhibitors to likely pathogenic also?
So in likely pathogenic cases, essentially, I think the guidelines don't suggest likely pathogenic, but this is completely a clinician's call. We have even seen clinicians trying PARP inhibitors if it's like the last option which is available, with cases of VU as well. So again, this is something which comes from pure experience, and
it's not evidence based, but has been tried as a last resort.
Correct. So if it's completely the clinician's call. If they think the patient might benefit with the PARP inhibitor therapy, it can be given for likely pathogenic cases as well.
Fine. Thank you very much. Dr. Maria Mir has shared one feedback that NCCN has very low threshold for recommending genetic testing, as it is an expensive test with implications. We usually do Manchester scoring first. Any comment on this?
So we don't really refer to the Manchester scoring. Again, I think NCCN, the most recent guidelines, is pretty pro-genetic testing and very inclusive, I believe, the most recent one. There is one released in 2023 only. So that one is pretty inclusive of a lot of other genes than BRCA1 and BRCA2 only, and it's talking a lot more in detail. So essentially, when I'm talking about the NCCN guidelines, we are only in my presentation, I took only the management plans from the NCCN guidelines. Most of the recommendation for the genetic testing, whether an individual qualifies or not, that is again, like I said, something which comes from more of personal experience to understand the age of onset, the type of cancer, the kind of family history that they have. It basically is something which is more driven from that.
Okay, thank you very much. So there is a last call for the questions from the forum, from the audience, and because I think we have discussed almost all the pertinent aspects of genetic breast cancer. In fact, we discussed in great detail and in a very simplified form. We learned a lot from today's forum. That at least I learned a lot from, and I hope all my audience also have the same opinion. So in today's forum, we learned about the test. So please, all dear audience, I request you please stop prescribing BRCA one or two mutation analysis or HBOC gene panel. What I understood from today's program, multi-gene panel for breast cancer, and it will assess all the genetic mutations, even the major and the minor mutations. It can screen out. So this is the one. तो हमें जो important test कराना है, whether the patient is affected or asymptomatic, is multi-gene panel for breast cancer. एंड इसके अलावा अगर वो निगेटिव आता है देन वी गो फॉर MLPA टेस्ट. वो एक दूसरा टेस्ट है. हमने कॉस्ट पता किया कि कितना अप्रोक्सीमेट कॉस्ट होता है. सो इन केस अगर कोई भी कंपनी आपसे ओवर चार्ज करती है, यू कैन आस्क देम, यू कैन नेगोशिएट विद देम, और यू कैन सर्च फॉर सम अदर रिलायबल कंपनीज विद रीजनेबल कॉस्ट फॉर योर पेशेंट. ओके. एंड हमने डिस्कस किया कि हमारे कौन कौन से पेशेंट्स हैं जिनमें हमें कराना चाहिए, नहीं कराने के क्या नुकसान है, कराने के क्या फायदे. एवरीथिंग वी डिस्कस इन डिटेल. एंड नाउ बिफोर वी वाइंड अप दिस मीटिंग, कपल ऑफ अनाउंसमेंट, and then I will ask Professor Chintamani sir to tell something about ASOMA, enlighten us with this rich forum that he has created. First of all our meetings are recorded. As we all know, the meeting will be uploaded on YouTube soon, so that anyone who has missed the meeting can revisit and can again learn from this meeting. Okay, friends, those who practice endocrine surgery, endocrinology, we have very interesting topic that we will be covering in November, Endo Meet. So please stay connected with us. I'm very happy the love and support I'm getting from each one of you. And now I request Chintamani sir. Sir, can you please tell me what is this ASOMA? कैसे स्टार्ट हुआ, कैसे आपको कैसे लगा कि ये एक बहुत इम्पोर्टेंट फोरम है जो कि होना चाहिए, क्योंकि एशियन पॉपुलेशन के बारे में शायद ही कोई इस तरह की एसोसिएशन, और इट इज गेनिंग रियली अ वेरी गुड मोमेंटम, getting attached to it. And I know you personally, आप कितना dedicated सबको पढ़ाते हैं, the cadaveric dissection, another thing, teaching and training program. So can you please tell me something about ASOMA and the upcoming conference that is going on?
Well, thank you, Dr. Sudhi. It's such a joy to be part of your forum. First of all, it all started way back in 2012 when I was the National Secretary for ASI, and I was keen that we have some organ-based specialization. Friends got together, and Dr. D.D. Patel that time was Devendra Patel from GCRI, very senior gentleman. He's no more, God bless his soul. We got together to push for a breast-related specialty, which was the beginning of EBSI. So I was the founder, president-elect. We started it, and that was only for surgeons. So over a period of time, we realized it was getting mostly for the surgeons. So we, I was attending a UREMA meeting in Oman, and that was a meeting led by Veronesi. And they asked if I can do UREMA meeting in Delhi. So I said yes, I'm willing. We started preparing for it, but we lost Dr. Varanasi, the Professor Varanasi, in the same year due to disease. So that conference was not happening, and he, in fact, was very keen that we start an Asian society on the same lines. So the term SOMA was coined based on the USOMA, European Society of Astrology, Eurasian Society of Astrology, and created Asian Society of Astrology, and in nearly 34 countries that joined us. The first meeting happened in Singapore, we did at Maldives. The last one happened at Ames. Then before that, the next one happened at Ames, then at Jaipur, then at Raipur, and also Bhubaneswar. And the seventh one is going to happen at Dehradun. So this Asian Society of Astrology is deal with the Asian data. As you rightly said, we don't have our own data. We don't know our cancer. We are just replicating the trials done in the West, which may not be always working in our favor. We are sometimes taking wrong decisions for our patients. And as I mentioned, we can't do screening our patients. They're too young for that. And the breast is dense. Can we use ultrasound for this? And there's a very good trial that is being presented in ASOMA by Bangladesh group. They've worked on ultrasound in the field, and they're going to publish that data very soon. So they're going to present that data. We're joined by the European Central Consortium of Cancer. They are going to present the Zoltan and group. They're going to present from Hungary, Poland, and all those Central European countries, their data. We joined by African Society, Egypt and other countries are going to present their data of breast cancer. We're basically trying to find our answers to the questions. We joined by of course, the European Society, that is ESSO joined us last year. We are hoping to join this year also. Generally speaking, it is about Asian doctor, which is mostly India. So India is leading that group, and yours truly is the founder president. So we started uh, 9 years ago. Now we do regular meetings. We're coming out with a journal very soon, and I would want you to be an active part of this society. Our conference is happening 15th to 18th in Himalayan Institute of Medical Sciences at Dehradun. They have a cancer center, very large cancer center. First day is dedicated to cadaveric workshop. They have a state-of-art cadaveric facility. We're going to demonstrate all oncoplastic surgeries. We make them students do hands-on. We're already full with our registration. Nearly 49 people have registered. We take a so the others are usually the postgraduates who are also registering, but they will not be counted in this. We're not charging them. They can observe. So the hands-on people are on. Then we'll have as you showed, the imaging workshop. We're going to have an radiation oncology workshop where they're going to show how the molds are prepared to teach surgeons about how is a scar important for them. Why should you place a scar in a particular position? And we're going to have a complete oncopathology workshop where hands-on, you know, how do you, apply the ink? How do you fix a specimen there to be taught? We do that regularly, and 3 days of videos, debates, panel discussion. It's a very, very rich academic activity. So I welcome you all, and we will be very happy to share more about it. You can always visit the website. Every detail is there. I'm looking forward to having you all there.
Thank you very much. And this forum is really very appealing because, like Brendos, we both sound quite similar because it is also multidisciplinary. So all those doctors who are either pathologists, radiologists, Asoma has so much for you as well. If you really want to
We have
grow,
members, sorry, we have members. I forgot. I'm glad you reminded me. Radiation oncologists, pathologists, breast nurses. Then we have geneticists. We have, the radiologists, breast radiologists. So it's like a MDT glorified. So everybody is going to contribute. We learn from each other. That's what we need to do.
so we learn from each other, and that is important because in today's world nothing is in isolation. So we all work in unison. Surgeon, we cannot work without a good oncopathologist and oncoradiologist. Similarly, oncopathologists and oncoradiologists, they need good surgeons, and they must know like what the surgeon wants and what the surgeon wants from the report. So it is something like this. So it's a very good forum. I personally recommend each one of you, and so through my various forums what I have, I would certainly like to uh, campaign for you so that you have already you will be having a good number, but a small effort I will certainly try to put from my side so that and I wish very good luck for you and your conference and the whole of your team. And friends, today it was really a wonderful day, a wonderful evening we had. We learned a lot from each other, and it's really memorable for me. And with this, I request you all. Now our time is also up, so that we can leave the meeting with the promise that those who deal with thyroid surgeries, please keep your last Friday of November fixed at 7 p.m. so that we join again and we are going to learn something about thyroid surgery. This is a small hint that I have given today. We'll be sharing the details soon. And this meeting will be uploaded soon. So anyone who has missed the meeting due to any reason can revisit this meeting and can learn from it. Thank you very much, sir. Thank you very much, sir, for joining us. I know you have a very tight schedule and you have come to Pune to deliver, to attend a conference, and uh, you have given us this much time. It means a lot to us. Thank
Pleasure.
you.
Pleasure.
Thank you, Dr. Divya. Your presentation was really enlightening. I learned a lot from you. Thank you very much.
Thank you. Thank you so much.
Thank you, all our viewers and audience, for remaining connected with us and be a part of it. It really motivates me and my team. Now I'm closing this meeting. Very good
Thank
night to all of you. Thank you very much.